All right, let's get right into it. Welcome to this explainer. Today, we're tackling a genuinely intense topic, recognizing and managing the highly lethal extremes of thyroid disease, specifically thyroid storm and myxedema coma. We're looking at situations where the human body's metabolic engine either revs completely out of control or just grinds to a devastating, icy halt.
Now, you might be wondering why the urgency? Well, the stakes here are quite literally life and death. Even in modern, top-tier intensive care units, untreated thyroid storm carries a double-digit mortality rate. We are talking anywhere from 10 to 30%. And honestly, myxedema coma is equally, if not more, dangerous. This makes rapid clinical recognition absolutely crucial. You simply cannot wait around for a definitive lab test to come back before you act.
So here's our roadmap for today. First, we'll cover the extremes of thyroid disease. Second, recognizing thyroid storm. Third, we'll break down the BBSIT treatment sequence. Fourth, unmasking myxedema coma. And finally, reversing the deep freeze.
Okay, let's jump right into Section 1, the extremes of thyroid disease.
Think of this as the ultimate fire and ice contrast in endocrine emergencies. We're looking at the absolute clinical extremes here. On the fire side, thyroid storm hits you with hyperthermia, extreme agitation or even psychosis, and severe tachycardia, very often throwing the patient into atrial fibrillation. Then, on the ice side, myxedema coma presents with profound hypothermia, severely altered mentation or a true coma, and a dangerously slow heart rate. It's essentially a complete systemic breakdown, just in totally opposite directions.
Moving right along to Section 2, recognizing thyroid storm. Here's the tricky part, though. Patients don't actually read the textbooks, right? While younger patients might look classically stormy, anxious, feverish, visibly shaking, older adults often present in a completely different way. We call this apathetic thyrotoxicosis. They might just look lethargic, weak, and hypotensive. It dangerously mimics sepsis without a source, or maybe it just looks like new, tough-to-control heart failure. If you aren't keeping a high index of suspicion, you will absolutely miss it.
So how do we catch it? Well, since there's no magic, definitive lab test that perfectly separates severe hyperthyroidism from an actual life-threatening storm, we lean heavily on the Birch-Wertowski point scale. You accumulate points really fast based on the patient's temperature, heart rate, CNS effects, and GI symptoms. A score over 45, that makes thyroid storm highly likely. And here's the major takeaway. If that score is high, you have the clinical green light to start immediate aggressive treatment. Do not sit around waiting for those free T4 and TSH levels to tell you what your eyes already see.
Let's tackle Section 3, the BB-SIT treatment sequence.
Once you recognize the storm, you need an immediate action plan. And that's where this BB-SIT acronym is a real lifesaver. It's a step-by-step sequence to shut down both the production and the effects of all that excess thyroid hormone. You need a beta blocker to calm the nervous system, a synthesis blocker to shut down the factory, steroids to halt peripheral conversion, iodine to block the release. And finally, you've got to find and treat the trigger.
Now hold on a second. Let's zero in on step 4, iodine. I cannot overstate this pharmacological nuance enough. Iodine blocks the release of preformed hormone. But if you give iodine before a synthesis blocker, like PTU, you are literally just throwing gasoline on the fire, giving the thyroid extra materials to build even more hormone. You absolutely must give the synthesis blocker first, and then wait at least 1 full hour before giving the iodine.
This whole regimen tackles the storm from every conceivable angle. We're using high doses of propranolol, not just to slow the heart, but because at high doses, it actually blocks the body from converting inactive T4 into the active T3 hormone. We use PTU to shut down hormone synthesis right at the source. We add hydrocortisone to give the adrenals some much-needed backup for this hypermetabolic state. And finally, Lugol's solution, or SSKI, acts as a roadblock, trapping the remaining hormone inside the gland.
All right, shifting gears to Section 4, unmasking myxedema coma.
Let's talk about the ICE. This condition is a massive, profound, multi-system shutdown. The classic profile you'll hear about is an elderly female brought in during the dead of winter. But what's actually driving the coma? It's often severely reduced breathing, leading to CO2 buildup, combined with profound hyponatremia, because the kidneys just kind of forget how to get rid of free water. And remember, there's almost always a trigger here too, usually pneumonia or some sort of sedative, that tips a chronically hypothyroid patient right over the edge.
Just like the fire, the ICE has a scoring system too. We use this to objectify what we're seeing, adding up points for hypothermia, bradycardia, altered consciousness, and metabolic issues.
If a patient hits a score of 60 or higher, that strongly points to myxedema coma. At that point, it's a straight shot to the ICU for aggressive intervention.
Which brings us to our final section, reversing the deep freeze.
Okay, pay close attention to this part because it is absolutely critical. You must give stress dose steroids like IV hydrocortisone before you give a drop of thyroid hormone. Why? Because these patients very often have an underlying adrenal insufficiency. If you rev up their metabolic engine with thyroid hormone, but you don't give the adrenals the support they need, you'll chew through whatever tiny bit of cortisol they have left, and that will precipitate a fatal acute adrenal crisis. Steroids first, always.
Once those steroids are safely on board, then we can replace the thyroid hormone. Now, there's a bit of an ongoing medical debate here. T4 is a pro-hormone, and a healthy body easily converts it to the active T3. But severely ill ICU patients suffer from what we call hypothyroid 6 syndrome. Their bodies just can't make that conversion effectively. Because of that, many leading experts advocate for a smart compromise, a combination of IVT4 to rebuild the body's storage, alongside a low dose of IVT3 to give the brain and heart immediate active metabolic support.
And because this is a multi-system failure, the hormone alone just isn't going to cut it. We have to treat the underlying triggers aggressively. We intubate for respiratory failure. We start broad-spectrum antibiotics because these patients literally cannot mount a fever, so a deadly pneumonia might be totally hidden. For the severe hyponatremia, we carefully push hypertonic saline. And here is a massive pitfall. Rewarming. You must use slow, passive rewarming with ordinary blankets. If you slap active heating pads on them, you cause sudden peripheral vasodilation, and in their hypovolemic state, that leads straight to cardiovascular collapse and shock.
So as we wrap up this explainer and you head back out into the clinical world, or just reflect on the extreme limits of human physiology we've explored today, keep that index of suspicion sky high. These diseases hide in plain sight. They disguise themselves as heart failure, psychiatric breaks, or vague infections. So the next time a patient rolls in with vague sepsis or a sudden, unexplained mental shift, ask yourself, are they hiding a highly lethal thyroid emergency right in front of your eyes?